Hello, hello. How is everyone doing today? Welcome. I hope you're having an amazing, amazing day thus far. I always have to remember that people are in different time zones. So for me, like the day is just starting. I even have my like matcha green tea ready to go. I know for other people, well, you're on. I just found out, Carolyn, like you're on the West Coast with
Yeah, on
me.
the West Coast here at Stanford. Yeah.
Yes, so you know the day is just starting for us. There's some people where it's midday. They're winding down for lunch. They're taking a break. There's other people in different countries that are literally like ending their day. It's the afternoon. There's people in Hawaii that are just like waking up
Crack of
or
dawn.
potentially
Yeah.
still sleeping. So it's always boggles my mind. So, well, everyone joining us now, welcome, welcome. Thank you so much for coming out to one of the International OCD Foundation's live streams. So every Wednesday at 9 a.m. Pacific Standard Time, with it being 12 noon Eastern Time, the Wednesday live streams are always going to have different clinicians on and different providers on that are going to talk about what is the latest research, answer your questions, what are some resources. If this hasn't been working, what else is there out there? So we're really, really excited to just be here today. Obviously, it's your live stream. So the more active you want to be, the better. So if you want to ask questions, if you want to talk to other people in the chat, if you want to make a comment about your recovery or what worked or what didn't work, we love that. So I always like seeing people supporting each other in the chat or asking us questions. Like I said, we have a ton of pre-submitted medication questions, but we also have, I want to make sure to get to the questions that get put up in the chat. Today's the second Wednesday of the month where we always bring on a provider who knows about medication, but beyond that, what is the latest research on different interventions outside of medication? A lot of times I like having them on because we have questions about, you know, hormones or genetics and those kind of things that I feel like they're most equipped to answer. So we're going to have all those questions. I'm a licensed clinician that treats OCD, body dysmorphic disorder, and related disorders. So if you have a question that's not about medication, totally okay. I'm here to answer that from both my lived experience. I live with OCD as well as my clinical experience. I'm a licensed therapist. But we have Dr. Rodriguez on as well. They can answer questions. So this stream is for you today. Jump in, add. I always like to find out where people are from and who they're here to support. So if you'd like to let us know who you're here to support, are you supporting yourself? Are you a licensed clinician or a student or an associate learning about OCD from this? Are you a parent, a guardian? So please let us know. But like I said, we're here every Wednesday at noon Eastern, but we aren't the only live streams. So make sure to head over to iocdf.org/live streams to see what other live streams we offer. All right, so I'm so excited. Before I jump in and we talk to our guest, always just quick announcements. Remind yourself that this is not a replacement for therapy. So if you're really, really struggling, obviously we're happy to have you here. But if it gets to that point where you need support, make sure to either call 988, go to 988lifeline.org. You can also call 911 or go to your local emergency room. We're here to offer community and support, but we can't step in and offer clinical treatment. And then, of course, this is being live streamed and recorded on all different platforms. So be kind to each other. That's all we ask. Well, Dr. Rodriguez, welcome for being my guest today. I'm so excited to have you all the way from Stanford, West Coast. Go ahead and introduce yourself a little bit. Let everybody know a little bit the exciting stuff about you.
Yeah. Well, it's great to be here, Chris. Always a pleasure to talk to you. I'm such a big fan of Ask the Experts and all the different platforms that IOCDF does to reach out and to communicate and to encourage people and to provide hope. I think that's really important. And I'm just such a big fan. I'm happy to be here. My name is Carolyn Rodriguez. I'm a professor here at Stanford, and I wear a couple different hats. So, I see patients in the Stanford OCD clinic. I also direct an OCD clinical research laboratory. We have a lot of different kind of active research studies going on, things ranging from understanding the mechanisms of ketamine in OCD. We're conducting a study of combining improv with cognitive behavioral therapy with exposure and response prevention, or ERP. We also do work in transcranial magnetic stimulation, and we're just launching a study of MDMA with combining it with ERP. And so, that I'm coming at this from those experiences. I also work at the Palo Alto VA with veterans as a consultation liaison psychiatrist, which means that I treat anybody who is coming to the VA who has a psychiatric condition. So be it bipolar, or schizophrenia, or PTSD. So I see a lot of range of the our field, and come at it from that perspective too. So a pleasure.
Well, what don't you do? Geez. What's so I run support groups during the week, and we always have an icebreaker question.
Yeah.
So I always like to get to know my guests more. So I'm trying to think if I'm going to ask you the question from last night, or well, this was a question last night, so it's kind of putting you on the spot. But the question was, what is your favorite sentimental object, like something that you own that has like a special meaning, or you love it, or it'd be like the first thing you'd grab in an emergency?
Yeah. It's funny because I also do hoarding disorder research, and so there's always, like when we do teaching and things, there's always like, uh, uh, different objects. So I have like couple kind of go-to objects or things that are very meaningful. But one of them is a little ceramic pig that I
Mm.
got when I did medical away internship in Chile, and it was at a time when I was feeling really, far away from family and home. And I saw it in this little artisan store, and it just reminded me of a little pig that I had made, a ceramic pig, when I was little, and it was just a very treasured object. Yeah.
I said for me, beautiful. I said for me, like pictures and yearbooks.
Yeah.
I was such a picture person, and I have my yearbooks for some reason, and I've always thought of it like that's the first thing I have to grab, because you can't replace pictures and yearbooks and memories and stuff. So, but yeah. Well, I'm gonna jump in, but I want to, talk to you about a couple different things. A lot of times, one of the big questions I always ask, and I'd love to get your perspective. When is it time for someone to explore whether that's medication? Let's maybe start with medication, and then I'll move on to the other options that we have out there. When is it time? Because I think um, that's kind of a question I get a lot, is like, Chris, do you think I should start medication? Am I a good candidate for it? So when do you see somebody with OCD? When does it make sense? Like, hey, maybe you should explore going on some medication.
Yeah. Chris, I love that question. That's a great question. And just, I think, taking a step back, because the audience is pretty broad, right? I see people from Poland and Cape Town. So welcome, everyone. Um, we know that obsessive compulsive disorder, just for everybody to be on the same page, is comprised of obsessions, intrusive thoughts, images, and urges that increase anxiety, and then repetitive, ritualized behaviors. They can be actions, they can be mental rituals that an individual does to neutralize that anxiety. It has to be more than an hour a day for at least a year at a time, and it has to cause distress, and impairment in social, occupational, or other important functioning. And so, I think that's the key, right, to your question, which is it impacting? Is it impairing? Are there things that you can't do? I often ask individuals, like, if I gave you a magic wand, right, and you could do something that you can't do, what would it be? If they're already doing everything that they can do, then it's probably not time for treatment. And so then, the American Psychiatric Association has recommended two first line treatments, either cognitive behavioral therapy with exposure and response prevention, or ERP. I'll call it from ERP from now on, that therapy, or medications like SRI, serotonin reuptake inhibitors. And so, oftentimes, because ERP is so effective and doesn't have side effects, and anxiety is a side effect, other than a little bit of anxiety, right? There's no downside in starting there, right? But if you're still having impairment, then you can always add on medications as well. So that would be like, if there's something you can't do, that's the question to ask.
Yeah. And then one thing that I struggle with a lot is I work with clients that I think need medication. They've tried a lot of really good treatments, great providers, but just sitting with them across the, couch, just high anxiety, really difficult to focus, giving into thoughts. And it's almost like treatment doesn't even feel good, or they're not seeing the benefits because there's such a kind of an association with those thoughts and those feelings and
Yeah.
struggling and things. But I get a lot of people, especially if somebody is like a teen with parents that are so afraid of medications. I think unfortunately with OCD, we're so smart and we're so intuitive and we're so investigative, but sometimes it can backfire. So I have clients that are like, I'm not going to take medications because of the side effects, or it's going to make this worse or that worse. So I read this. What do you think is that cause? What do you think it is about medication that gets so many people kind of avoidant or scared? And have
Yeah.
you seen something that you find that really helps people see why this might be
Yeah.
helpful?
Yeah. Well, I always like to say not one size fits all. And there's a lot of treatment strategies out there with more to come. And if for whatever reason, medications, you're nervous about them, the side effects, sexual side effects, or you've tried it and had a bad reaction, that's okay. There's ERP. ERP is really wonderful. And I think sometimes people can get into ERP that is maybe just once a week, but you can actually, just like medications, titrate up the dose. You can do it twice a week. You can do a more intensive ERP. You could do a residential program. You can do there's a kind of a ladder, right? And Chris, welcome to speak more about it. But the other thing that is an option is their FDA approved transcranial magnetic stimulation that is approved, and you can get insurance reimbursement for. So that is not a medication, right? And so that is potentially another avenue to help. As well, there's less evidence, but there are things that can be helpful for anybody who is struggling, right? So things like getting good regular sleep, a diet, trying to eat clean, healthy foods, as well as doing things that are, good for coping in terms of like mindfulness and exercise. Those are just kind of core principles.
Yeah, I'm glad you spoke on that. And there's a question about that. So I'm going to ask you something in a second. But when I was doing a talk once at UCI, it's a university out here, and one of the speakers before me spoke on some of the research on general anxiety. It wasn't OCD specific, but it was twin studies. And it was like one twin where they didn't touch, like that twin lived their normal life. But the other twin really focused on kind of, I think they focused on like 10 wellness kind of like improvement factors. So sleep, I think they had like a Fitbit or something they're using to track sleep to make sure they were getting 8 to 9 hours. Regular exercise, like you said, the study provided like I don't want to say catered meal, but like kind of meal preps and stuff. But they were, doing a course on mindfulness. I think they did a course on CBT as well, but they focused on just like general wellness that we all kind of like read in an article and we're like,
Yeah,
yeah, sure, who actually does that? But you really need to do it with OCD.
yeah,
But when they came back, I mean, I remember it was so long ago. The talk was pre-pandemic, which feels like ancient. But I just remember like the results, and they were talking about it in this presentation that I was speaking of OCD about. But the twin that was really taking care of themselves, not only self-report measures reported feeling a lot better, but just like cortisol levels were down. Like, I think one of them had a rash that went away, and it's just certain things from the research. But I've always thought, like, if you're going to be battling this disorder, because this disorder is a beast, why not be in the best mental
mhm,
place? And I always say, like, some people for whatever reason can like sleep for 2 hours and be great the next day. But for some people, if they get 7 hours instead of 8, their mind's racing. So I'm glad that you brought up taking care of yourself. It's tough, it's challenging, but what I always say is like bring it up to your therapist. If you're having something really struggling with sleep or with diet or exercise or movement or any of these things that we know could potentially help you just with your general wellness, we also work with that. So definitely bring that up.
yeah. Chris, I just wanted to add here that, sometimes OCD can be made worse by co-occurring conditions like PTSD, depression, um, and sometimes people can reach out to things that to cope with having obsessions and compulsions, which is, I don't think the general people out there realize how much of it is a prison, right? A prison for your mind and your thoughts, and people are feeling tortured, right? And so it's understandable that they may reach out to other things for coping. But things like alcohol, although may transiently maybe help a little bit of anxiety, you can have rebound anxiety. It can make things worse, including drugs. And so, paying attention to treating co-occurring illnesses, right? Some people have had hardship and they have nightmares and flashbacks. Um, and you can do that kind of treatment. That can also help, right? As OCD, it's like having a backpack, right? And you're kind of weighed down by OCD, but then if you have co-occurring conditions, they can also weigh in your backpack and make it harder. So if you can get treatment from some of those co-occurring conditions, the backpack can be a little bit lighter for you.
Yeah, I mean, I don't always talk about it, but I'm sober. I don't think I necessarily had a problem with alcohol, but I found out really quickly in high school that to get rid of my intrusive thoughts, if I drank, I didn't have them. But the problem was that, when I got older and had a better understanding of the condition, I'm like, I don't think this is making us better. In fact, I think it's making it worse. So when I started my medication, I'm not on medication anymore. But when I went on medication for my treatment, my OCD was so rigid. So when it was like, hey, you should probably not drink, even whenever a doctor would say something like, well, you can drink a little bit, but my brain was like, nope, you can't drink. So I stopped drinking because of the medication. But then as I got better, I noticed like, wow, like not drinking was better for me. Now, I'm not saying it's better for everyone, but I do talk to a lot of clients and, they'll admit like, hey, I'm using this substance or I'm drinking or something to cope. And I always try to normalize it like you just did, because we all are just seeking relief.
Yeah.
But what I see, unfortunately, over time is it typically just makes it worse. So I always promise them like the treatment, whether it's medication and ERP or, whichever one you choose, hopefully ERP is in there somewhere. You can get that relief that you're seeking, but get it at a consistent basis. And I think that's why, I never went back to it, because I was just like, I don't need it anymore. I was only using it to cope. But I'm glad you brought that up, because I think there's a lot of shame sometimes if people are using something to try to cope.
And I noticed one of the comments is that when they quit heavy drinking, started to feel worse, and that can happen, right? You can have withdrawal, and so it's important to not stop, cold, but to really do it in tandem. Sometimes therapists and mental health providers can have something called dual diagnosis treatment, where they can work together with you to help with the alcohol, to help with the OCD together in tandem. And withdrawal is a real thing, right? It's your body's reaction. So, just want to do it gingerly, want to do it with a provider, and not feel like you're alone in this. This is something that we see, something that's common, and you can get help for it.
Yeah, and I always remind people everyone is different. I had a client report to me recently that they've quit vaping, and it's been like the best thing for her. She's like, my anxiety's down. It's great. I just didn't buy a new one, cut cold turkey. I had another client that wanted to quit smoking. And it was hell for him because he wanted to go cold turkey, because we tend to have a black or white mindset with OCD. So he went and did more of like the patch and kind of did it systematically, and then felt better afterwards. But the process was a lot more, enjoyable doing it, not cold turkey. So I think wellness, we're learning so much now about, the mind gut connection. There's so many things coming out there. Obviously, we know the heart of recovery is going to be ERP and some kind of medication if people need it, or TMS or these other interventions. But focusing on wellness is not a bad idea either. I wanted to throw this question out to you at 11:33. Alex, she wrote, said, what are some proven natural treatments for OCD in terms of supplements, etc., or natural things that help? Sometimes exercise helps, and sometimes it makes my anxiety worse.
Mm-hmm. Well, I was just going to add into the chat here. We had done these ADA through ADAA, these like practice guidelines. And so maybe Emilio can help me just kind of put this into the general chat. But it goes through some of the like first line, treatment strategies that we talked about, and kind of further down talks a little bit about the other options. And so they're in terms of complementary alternative treatment. So the guidelines say currently no treatment guidelines recommend the widespread use of complementary and alternative medicine for OCD. There's one study that suggests 8 1-hour sessions of mindfulness meditation is beneficial, and another one suggests that OCD patients can benefit from 3 weeks of electroacupuncture, but they're not randomized, right? These are just like kind of single studies, and so we really need more research. St. John's Wort has not been shown to be effective, and things like stress management, CBT. Has also not been shown to be effective for OCD. So, but that said, again, come back to not one size fits all. You test these things, right? Test mindfulness, test exercise. I'm not saying go out and just do every single thing, right? Try one at a time, and you yourself are an N of one experiment, and you know your body best, right? So try first as a first step. Try to get a regular bedtime in. Try and really optimize your sleep regimen. Try and get like the warm milk, the warm shower, whatever you need to do. No electronics, right? Just reading a good book or listening to music or doing. My daughter was just saying the savasana, which is just, I think, just lying down on the floor. That sounds pretty good, right? Try those things and try and just get regular sleep, regular bedtime, regular morning, and try that for a couple weeks and see how you feel. So that kind of thing.
Yeah, thanks for that. When we were talking a little bit beforehand, you're talking about some exciting research that may be coming out, and just things that are studied. So I know that obviously medication is an option. You've talked about TMS, transcranial magnetic stimulation.
Mhm.
Obviously questions that I get consistently is like, have mushrooms or psilocybin found useful? What about MDMA? What about ketamine? Beyond medications, you could also talk about TMS a little bit, but what are some of the exciting things in the pipeline? What are we seeing? And I think also is like, when should that happen? So I know for my treatment, for instance, like did ERP for the first 6 months without medication, hit a roadblock, got on medication, and then kind of sprinted to the finish line. And after about 2 years, was like done with formal treatment. Obviously, you're still in it when you're facing it. But my point is, for not everybody's story is like mine. We have a pre-submitted question I'll ask a little bit later, but someone just saying like, I've tried 6 SSRIs, none of them have been able to be tolerated. So when do people kind of know, hey, we should look at other options, and what are some of the other options that we have out there?
Mm-hmm, mm-hmm. So the first link, the ADAA treatment guidelines, kind of goes through the algorithm, right? Which is like, if you've tried an SSRI and it doesn't work, try and switch to another one. You can try the list of SSRIs that are there. So the FDA-approved SSRIs for OCD include fluoxetine, fluvoxamine, paroxetine, and sertraline. And you want to take them for high enough doses for long enough period of time. So unlike in depression, OCD, you need higher doses. And you need to continue them for 8 to 12 weeks, including a 4 to 6 week at maximally tolerated dose. The ones that are not FDA approved are escitalopram and citalopram. And then if there's no response to that, you can switch. You can also try clomipramine, which is a SRI, and those that are not approved for OCD, venlafaxine and mirtazapine. Then you can move on to try adding on an antipsychotic. And if you have a partial response to an SSRI, you can add, the other agents. So a little bit further down, second or third line, are things like memantine, pregabalin, topiramate, lamotrigine. So things that act through, instead of the serotonin system, act through the glutamate system, which is the main excitatory chemical messenger. These are also N-acetylcysteine. I've seen some people do well with buspirone too, as an augmenting strategy. And then, what if you've tried medications, you tried ERP, you've tried augmenting those things, and still not getting relief? I think having the FDA approval for TMS is a good thing. It has a nice randomized controlled trial. And just one word about TMS. So TMS is essentially a non-invasive way of stimulating activity in the brain using magnetic fields. Emilio, I just added another link, which is the International OCD Foundation convened a group of us to write out kind of like a little bit more information if you're interested in this, to give you a little deep dive. Like, what is it? How does it work? Kind of the nuts and bolts that you'll, what type of coils are used, that you're going to have, ear plugs in, kind of what to expect. And then similarly, that there are different types of transcranial magnetic stimulation. There's repetitive, there's deep TMS, and you can stimulate different regions of the brain. More frontal part, the anterior cingulate, add a little bit deeper structure called the medial, dorsomedial prefrontal cortex. So that said, I would, work in concert with a psychiatrist to get a referral, and try and find out more about it. In terms of research, we did a small pilot study testing the safety efficacy of a 5-day individualized protocol using theta burst stimulation, which reduces the amount of time that you have to spend in the chair with the stimulation. And we found that it produced a response rate, a greater than one time unit of 71%. This is an open label study. It's not randomized, but it shows that there are different, again, not one size fits all, that there are different types of ways that you can deliver transcranial magnetic stimulation, and they can be helpful to people. And maybe I'll pause there. Did you want me to talk a little bit about ketamine and
Yeah,
other
thank you
things,
for
or?
both of that. I hope
Yeah,
people got that, because I know it's a scary kind of like venture to go to.
yeah,
And like I was saying earlier, I think a lot of people have fears. They fear that the medication is going to cause side effects, or the medication is going to like impact somebody. There's just like a lot of resistance, and I
yeah,
especially notice it when it's a parent. And I'm hoping that as we do more live streams and the words gets out, I mean, like I said, sometimes people need it, can be helpful. What I get asked a lot are some of these other options that people are hearing are sort of in the pipeline, like psilocybin around mushroom usage,
oh yeah.
or MDMA, or ketamine, or these kind of like, hey, I'm starting to hear these kind of things coming out.
Yeah. Well, with psilocybin, there have been some open label studies by a group, Moreno et al., that have shown some promise. And then I know there's a couple different groups. So one of them is Ben Kelmendi and Chris Pittenger at Yale that are conducting a trial. So if you look at clinicaltrials.gov, if you look at that and do a search for psilocybin and OCD, you'll see all the places that are studying it. And I know there's another group in England, Naomi Feinberg is another group. And I, I want it'd be nice for it to come from them, because I know that there are studies in the pipeline that are working their way through the peer review system. And so I think that there will be some interesting and exciting findings coming soon. So I'll just say that.
Exciting, exciting. I'm going to ask a couple other questions that we've gotten pre-submitted that I think is exciting. So, this was pre-submitted, so I put it in kind of our back chat. But somebody pre-submitted and said, "Is there a time period or a particular age where OCD either peaks or gets worse or flares up?"
Yeah. Well, we know based on the data that around 25% of OCD cases will be identified by age 14. And so it's something that happens, and people start to get, more into disrupting life and functioning in that sort of pre-pubertal and pubertal age, just as like all, a lot of hormone changes are happening. And then we know that it has a waxing and waning course throughout the lifetime. That said, there are a lot of individuals that I speak to that say, I started to have this funny thought, ever since I was a child, right? Like that if I looked at something wrong, then I was a bad person, then I had to do some prayers to counteract it. So you hear a lot of times people where it starts a little bit earlier. And there is it's thought, one of the theories in the field is that there's an earlier onset that is more predominant in men, that can have a worsening course over time. But that's something that is still, an active area of investigation as well.
Thank you.
I would say also just flares, stressful times, right? A lot of life stress, sometimes having these kind of times where getting married, having kids, we see a lot of very like moving, big stressful event can also exacerbate OCD.
Yeah, I also see it a lot of times. I work with a lot of young adults and like that transition from high school to college. I see that a lot,
Yeah.
just because of like the stressors from moving out, being independent, being an adult. Also, I see it obviously perinatal. So, sometimes during pregnancy, post, pre, during. Sometimes clients will report feeling great. They're like, I love being pregnant. My mental health is great. And then unfortunately, sometimes after having the child, they're noticing that their OCD kind of flares up as well, or they have to get off their medications for pregnancy if that's what them and their doctor decides. And then suddenly it's like, whoa, I forgot how much the medication has been helping with managing the OCD. So,
Yeah, and also that question of not everybody should be off of medications. So it really, like you're saying, Chris, it depends on the provider in terms of pregnancy. So there's a whole kind of risk benefit ratio, because at the end of the day, mom has to be okay too.
agreed. Another pre submitted question we got was, I'd love to hear your insight into comorbidities with tic disorders and neurodivergent comorbidities. And then the second part is, and the big question is OCD considered neurodivergence?
Hmm. Great question. So I would say, the comorbidity with tic disorder or Tourette's, or any kind of repetitive behavior. So there is evidence-based treatment for these kind of repetitive behaviors. Chris, you could probably talk a lot about that. But there are things like CBIT and other things that are evidence-based that can be helpful. I would say also that some medications, some antipsychotics, can be helpful for individuals that have comorbid tic condition. So I think it's something to ask your psychiatrist and see if you may benefit, or your therapist to see if there's a different kind of therapy that could be helpful for it. I would say, in terms of neurodivergent, these can be things that range from like comorbid autism, ADHD. Um, I'm a big fan, as you've heard me speaking from the beginning, of really optimizing treatment for those conditions. And so autism is a pretty heterogeneous condition, and it can also include some of the symptoms that are OCD like, but it can also have repetitive behaviors. And in these cases, these are, kind of team of individuals that can really help in terms of managing a lot of different aspects. But we can't forget really the strengths-based approach to neurodivergence, where individuals can have really incredible strengths in terms of STEM fields and other, depending on what is happening. Individuals with ADHD are incredibly good at good under duress and emergency situations. Maybe it's EMT type fields, and so we want to also speak about neurodivergence in terms of what it brings to the table, and making sure people are living full and rich lives, and trying to, just as much as the treatment for the repetitive behaviors and things, are really helping people to shine and giving them those job and work opportunities as well, can be helpful. ADHD, they're stimulants, but there's also, for kids at least, there's something called contingency management training, which is a way to kind of educate parents on how to use rewards and behaviors to kind of help with the behavioral management of some of the frustration that can happen with ADHD. More often than not, individuals will require both therapy and medications for ADHD. So it's something that with a provider you could try and see if it makes a difference. And the question is OCD would you consider OCD neurodivergence? Chris, I'll leave that one to you. Do you have some
No.
thoughts we can co-answer together?
Yeah, that's a challenge.
Yeah,
Because real quick, going back to what you're saying, you made a
yeah,
really good point. Tic disorders have their own treatment, CBIT, and we
yeah.
know that there's a big comorbidity, so co-occurring with OCD and tic disorder. So if you are experiencing a tic disorder, make sure your clinician is specifically trained in CBIT and other interventions for tic disorder. And then yes, neurodivergent. I would say I see a lot of clients with co-occurring autism or OCD, ADHD. The hard thing about it is some people, like, that's why it's like it's such a hard question to answer, because there's some people that feel like OCD is a neurodivergence, and then other people say, well, when we look at autism or ADHD, for instance, like, people can't like treat it and manage it, right? Like, you're not trying to treat somebody's autism. They don't have a problem, right? There may be some difficulties with the way that they see the world or they experience the world, and how neurotypical people do. I my favorite person in the world, well, I have to say he's my one of three tied, so I have three nephews. So if I ever say one of them's my favorite, I'm going to uncle jail. But one of
Oh
my
no.
nephews who just turned 13, Dominic, he has autism, and it's like there's nothing to treat. Like, he doesn't have a problem, right? But there were certain things like wandering out of school and like trying to run away, or saying inappropriate words or inappropriate places, cursing and stuff, like we've worked with him on. But same with ADHD, right? Like, we're helping somebody manage some symptoms because they're really struggling with like keeping a calendar and making it to appointments on time, and being organized. But somebody with ADHD, you're not trying to like treat them, right? OCD, you are. Like, I don't identify with OCD. It feels like a hellish conditioned
Mhm.
experience. So I think with neurodivergence, we just got to be careful, because I think sometimes what people think is like, oh, that's just how you are, like, live with it, learn to thrive. And I feel
Mhm.
like OCD is a little different than that. But some people really feel like that title makes them feel empowered. So I'm never going to be somebody that wants to take it
Mhm.
away. But I don't think there's been like an agreement where we've like picked a side, in as long as I've heard,
Yeah.
as we have with autism and ADHD.
Yeah, absolutely. And I think just to add to that, I saw a presentation on neurodivergence. So Lawrence Fung here at Stanford has they have a summer camp and for high school students, and they do research and job. They have like a big conference, and I have really admired that. And when I heard him talk, he raised like an important study that is asking individuals from different conditions. Do they prefer the term, individual with autism, for example, or autistic? And the majority of individuals preferred the term autistic. And I think that part of it was what you were saying, right? The individuals are proud of the many strengths that they have, and they consider it part of who they are. They're autistic, right? Although some people still prefer the term individual with autism. But it is important to take cues from how the individual is speaking about themselves, and referring to them in that way. We do that also with individuals with hoarding disorder. Um, they might say, I'm a finder, I'm a keeper, I'm a finder keeper. So Lee Scher has really done a lot at IOCDF to educate people on the importance of words and respecting where they're coming from. For the most part, I've seen individual with schizophrenia, not schizophrenic, right? Because that is more persons centered language, and is recognizing that the fact that the voices and things, and the psychosis is impairing and distressing to the individual. So that's an example of where we wouldn't use schizophrenic. We would use individual with schizophrenia.
Yeah, it would be really weird to call myself like an OCDer or something. Like I just have never seen myself with that. Like I'm Chris who has OCD or, things like that. I always remember I'm still mad about this to this day. I'm going to need to come see you for some help. But when I was in grad school, I obviously my OCD perfectionism, I was always wanting to get good grades. I got all A's, woo woo, but I lost 5 points on a paper because I talked about my nephew as an autistic, and the teacher's like, nope, it's individual with autism, use person centered. But everybody in my nephew's community likes the term autistic, where I find that my clients with OCD would much rather prefer to say like, oh, an individual with OCD. I don't think I've ever met somebody that's like, oh, call me in. I don't even know what the term would be, like an OCD or sometimes like you'll see like really poor, it's not common, but like I've seen in the news or something, like when Greta Thunberg, I think, was coming out and she has OCD, and somebody was like, an obsessive compulsive person or something like. So sometimes those terms exist, but I just don't think many people like it in our community. So.
Mm-hmm.
This is a good question because, and I'm going to expand on it a little bit. This was sent to us right when we started at noon by C. Quaddy on YouTube. They say if somebody is seeing a therapist, so a PhD for OCD that does not prescribe meds, what might be a first step for that patient who might be interested in exploring meds for OCD? I think sometimes we just assume it's an obvious thing, but I know for me it wasn't. So let's say somebody's seeing a clinician. What is kind of those first steps? And then the part that I want to add, the second part is who can prescribe meds, and who should they see?
Yeah, absolutely. Happy to speak on that. So, typically, if you're seeing a therapist, they are very well connected in like the clinic and things like that, and they work in partnership with psychiatrists who are MDs, and those individuals have a license to prescribe medication. And so, the first step is obviously the therapist is a trusted point person. Talking to them about your functioning, how medication may play a role. Again, not one size fits all. So, working hard to see if the therapy can be optimized, um, and then just asking for a referral from the therapist because they likely have a network of individuals they can refer to, but also the International OCD Foundation itself. If you go to the link and it says find help, you can put in your geographical location, and then you can do different search fields. So you can search specifically for a psychiatrist or medication prescriber, and it'll give you a list.
Yeah, I was just looking at all the nice comments and people introducing themselves. Nathan at 1204 asked Carolyn, what about troriluzole?
Oh
Those just
yeah,
like
troriluzole.
roll
Yeah.
off your tongue, right? I'm like, whoever like names and like medications, like I would love somebody to be hired where it's just like it's like blunt, whatever it's supposed to do. Because I'm like, I need classes in how to say these medications.
Oh yeah, no, definitely. So I think at the top of the hour is introduce the concept that SSRIs work through the serotonin system to boost the amount of serotonin um, in the brain cells that transmit information in the brain, right? So a different pathway is by modulating glutamate. Glutamate is a main excitatory chemical messenger in the brain, and troriluzole is one of these compounds. And so for a long time, in terms of the history of the field, a lot of glutamate modulating compounds, so things like riluzole, which is like the precursor to troriluzole, memantine and acetylcysteine, these kinds of drugs were explored. It was thought that adding them to an SSRI could be helpful in augmentation, and there's some studies to support that. And so that's why it's sort of further down in the algorithm of augmentation. And then I and others have done work in ketamine, which is also a glutamate modulator, can be IV infusion, and shown that it can have rapid reduction in OCD symptoms for about half of individuals. We've done it as a randomized study using saline as the control, which isn't perfect because usually when you want to blind, you want to disguise the effects. And we just finished a study looking at midazolam, which is a drug that makes you feel woozy, and we're able to replicate our findings. So that is also kind of supporting this glutamate pathway. And now troriluzole was originally made, had They wanted to sort of optimize it because it had some good effects to not have as much effects on liver enzymes. And so they made a new formulation called troriluzole. And when you have a new drug, it has to go through several phases of clinical trials. We actually were a site and participated in the phase 2 troriluzole study. Now it's even in the phase 3 study, which is like sending it out to a lot of sites, national, international, and doing a randomized controlled study with a larger sample. So that's got the gold standard in our field and evidence that the FDA needs to say, oh, we should approve this drug by the FDA agency as a treatment for OCD. I will say we haven't had any FDA approved new medications that were specifically approved for OCD since the 1990s. And so troriluzole, part of the reason why we wanted to be a site is that it is something exciting, something new for the field if the data that's being generated right now looks okay. If you're interested in getting troriluzole, there are sites, including ours, throughout the US. So you can go to clinicaltrials.gov, type in troriluzole, and you can see the different locations. And we can also help connect you as well. In terms of disclosures, I will say that I served as a consultant for Biohaven, and again, we're a site for it. So, but my consultancy was to help advise on training the independent evaluators on how to do a good delivery of a Yale-Brown obsessive compulsive scale.
It's funny because I always, the way that I always, this is so random how my brain works, but the reason I always remember that glutamate rather is an excitatory neuron is because like I always kind of like how I studied for tests in school.
Oh yeah,
I was like, I'm so
mnemonic.
excited to work out my glutes, and that's all I'll never forget. This was so random. I'm sorry. People are like, boo. Okay.
I still had those too. I had for medical school. I had these like groans, bones, and psychic moans for specific disorders. So they're mnemonics are great.
Yeah, I just picture like somebody, like a guy on the like Stairmaster with weights, and he's like, "I'm so excited to work out my glutes." That's how I remember. It's the most random ways that I remember things. Like the hippocampus, like hippos are on campus because they want to learn and memorize things, like because it works with your memory. So things like that is how I got through school. Eric at 1209 says, "Is it possible to completely cure OCD and anxiety disorders without meds, like just ERP, accepting and risking ignoring thoughts, and suddenly your mind becomes calmer as you do no compulsions?"
Mm-hmm. I think that is the goal, right? It's the goal to cure OCD, or in terms of like, as a clinician, to help people live their best life and do the things that they want to do. That's still possible if you have some OCD symptoms, like you're saying, in terms of like functioning and acceptance. So there is a pathway to wellness. And, that may look differently for different people. I'll say that. Chris, do you have something to add in terms of?
Yeah, I mean, I think sometimes people get caught up in the word cure, like what does cure mean, right? And I always tell people like a majority of us when we start our journey, 95 to 98% of our life is OCD if you're a severe case, and then it flip-flops, right? Like 98% is your life, and you might have 1 to 2% that you can manage. But I would say is like there are a lot of people that get better without any kind of medications or additional interventions outside of like CBT with ERP.
Yeah.
I wasn't one of them.
I've seen it.
Yeah, I've seen it a lot. I wasn't one of them. I mean, I spent the first 6 months without it, and I did really well in treatment. But like I said, I was a severe case. I was housebound for 3 years, suicide attempt, hospitalization, like not functioning. My dad was cutting my food up and feeding me. Like, my mom, I couldn't even sit in her house when we were finding a therapist because her house was like contaminated from chemicals. So I was sitting in the backyard. I mean, it was a pretty severe case. And the medication really aided me on my journey. But I always tell my clients, like, I don't prescribe. I'm not here to do that. I would love to find you a referral, but I'm here to work more on the ERP. And so I do, though, I'm honest with a client. If I feel like they're hitting walls, a medication would be helpful, or at least having an assessment with a prescriber. But yeah, I've worked with a lot of clients that do really well with treatment alone, and they don't need medication and they get a lot better. So this is hard. And I think what you want to do is when you build that relationship with your clinician, ask them questions, have them be honest with you. I'm always honest with my clients. So if you're really hitting some walls, you can ask, like, hey, is there something that I'm doing or not doing? Or do you think maybe it's because medication would be an aid in this journey?
Yeah.
So
And also part, just a portion of the research that we're doing is really trying to help people have gentle on ramps to ERP, which is evidence based. It's so helpful. We'll often do things like pair ketamine, with then exposure and response prevention, in mind that ketamine in animal models increases brain-derived neurotrophic factor and synaptic plasticity. Could it be helpful as a kind of precursor to ERP? Not to continue to take ketamine, but just as a way to kind of help people get onto the ramp of an evidence-based treatment. Similarly, we're testing that out with MDMA. It can be hard to expose yourself to the thing that you fear the most, but MDMA is very pro-social, and could this be a way to get people kind of more gently into ERP? Same thing was the idea for improv with ERP, which is the whole philosophy of improv is yes and, right? And so Elizabeth Andreff, who's running that study, is an improv, does a lot of improv herself, and just could see that maybe working together as a group and supporting each other in this kind of improv activity would help with flexibility and really easing people and making it a fun kind of joyful experience to do ERP.
well said. There's a two-part question for both of us. Christina P on YouTube asked, for Dr. Rodriguez, do you see any of these new treatments working in children? And then for me, I have a 10-year-old child with OCD-related behavioral issues. When is it appropriate to give a consequence?
All right. Maybe I can say the first part, which is, yeah, I think, one of the most heartbreaking things is, you know, uh, first, how long it takes for people to get diagnosed. So it can take anywhere from 14 to 17 years. So a lot of the people, because I work in adults, will see individuals that had these symptoms a long time ago but weren't recognized. And so I think more and more the field is recognizing, and due in part to the advocacy of you, Chris, and the International OCD Foundation. So now, if you have a child, right? So I work with child psychiatrists and ask them this question too. And oftentimes with parents, starting with ERP makes sense because of having, Chris, what you were saying before, some of the concerns with the side effects, but sometimes individuals need, the combination of both. Now with things, other more novel and experimental medications, typically it takes a while for it to be tested in adults and then translated to kids. And you always want to see like a randomized controlled study. So I know in the TMS world, more and more companies are doing randomized controlled trials of adolescents, right? And if those um, uh, um, those studies work well, then the plan would be to go younger, and you can already start doing ERP and medications in younger kids, again in consultation with your therapist. Okay, I'll tag team you.
Yeah, what I was going to say is it's a fine balance, Christina, and it definitely give yourself self compassion and grace, because it is kind of like that fine line. So what I always educate parents is we don't want to punish your 10-year-old for having OCD. And with that said, if there's certain behavioral issues, breaking things, yelling, hitting a sibling, etc., obviously it always helps if you're working with a clinician. So, I was actually just working with a family yesterday where the brother and sister really clash over some things, because there's some non-OCD things involved, and that might, be better to handle with family therapy. But there is some OCD things involved where the brother isn't doing certain things and it's causing this, my client to get agitated. And so what I always strongly push is like, you want to have that separation when you do talk to your child and say, look, you're not being punished for the OCD, but you're being punished for how you chose to respond to it, we can't hit. So what would be better is like, as a family, have certain rules. You don't want those rules to pinpoint the person with OCD so they don't feel attacked. So for instance, like one of my clients, the person with OCD has to do these like phone rituals at dinner, and it's really driving the parents crazy because they want it to be a non-technology dinner, but the siblings are also using electronics. So I was saying that the family has to, as a family, come together and say there's no electronics at the dinner table. It can't be like, you have OCD, you can't use it, but your siblings can. So you want to make sure that the rules are much more like universal for the whole family, and that way you can explain the difference to the 10-year-old as like, look, you're not being punished for having OCD, but this is an okay behavior. And if you're working with an OCD clinician, you can really parse that. But also it's helpful if the 10-year-old has tools to manage the OCD, so they're finding themselves not acting out and lashing out. But at 10, they'll start to understand like, okay, I always tell kids, I normalize their anger, their frustration, their sadness. They're just trying to figure out the world, right? Like everybody else at 10 years old, while navigating a horrific disorder. And with that said, it's how you react and how you respond. And so you don't want it to become kind of like a tit for tat punishment thing, but more of like an education, a learning how to help manage it. One thing I always do with my younger clients is give them, besides the ERP tools, but other tools to help like self-regulate. Sometimes kids like to go in the backyard and hit a punching bag. Sometimes they have like a quiet room, or there's something that they could go to that helps them navigate their strong emotions without doing it in a way that's inappropriate for the family and causes harm. There was a comment by Stephanie Ong at 1213 on YouTube that says ERP was just too difficult for me. She went on to say, I do mindfulness meditation and I find it to help. I was just going to add, like, I think you added some great stuff. Like medication can often help make ERP more manageable. I know a lot of clinicians are utilizing ACT, which is acceptance with commitment therapy, or known as ACT. And a lot of times ACT can really kind of do values-based treatment, use cognitive diffusion and some other tools that are helpful. But I know for me, a big part of my treatment, I did martial arts most of my life, and I learned a lot about like mindfulness, presence, centered, and those kind of things help me. Sometimes more CBT based interventions are helpful if people aren't really ready to face their certain things behaviorally. Sometimes dialectical behavioral therapy has some really great tools. John Hirschfeld just wrote a book using DBT skills for anxiety and strong emotions. So sometimes I have a client that they're so dysregulated from their emotions that doing ERP is really difficult because they're already so amped up before even starting the session. So I would say, Stephanie, sometimes a higher level of care, an intensive where you can spend hours with a clinician, so you're not doing it and then like leaving the session. So there are some tools, but I'm glad at least that mindfulness meditation has been helpful. It's always good to hear.
Chris, I didn't know you did martial arts. What discipline did you?
So it's called USSD, so United States Self-Defense, USSD. I stopped at the pandemic and haven't gone back. I did it much more like as a kid, and then I did it again when I was starting my OCD journey. And then actually when I moved here, I started to take a free class, and I kind of wanted to get back into it selfishly just to have some kind of exercise I didn't hate. And I did like 3 classes and the pandemic hit. So I need to get back into it. But I did. I mean, they focus so much. I remember after treatment, they focused so much on just like mindfulness and presence and being centered. And one of the things that I learned is, my sensei would always say is like, your problems are never occurring now. They're always either in the past and you're regretting something, or they're in the future and you're worried about something. But in the here and now, you're fine, you're safe. And so we do these like meditations, and I'd realize like, oh yeah, everything I came in obsessing about isn't really happening. It's not going to happen most likely. Let me just be present. OCD struggles to live in the present. So, well, that's our time. Carolyn, we're at time. What I always let people know. So some of the pre-submitted questions, we either get pre-submitted or I pull from previous streams that we didn't get to your questions. So if you ask a question, we didn't get to it because we had so many this week, this session. Please know they don't just I don't delete them. I literally, Emilio can attest, I stay out here and copy and paste all of them onto a document, put it at the top, and then really hit those first at the next stream. So if you asked a question, we'll be back here. Carolyn won't. She has a life. She's too busy. She's gallivanting around the world. But I'll be back
Yeah.
next Wednesday at 12
Yeah.
Eastern. And like I said, any questions we didn't get to, I'll make sure we get to. Any final thoughts you want to leave people with, Carolyn?
Yeah, I just want to let people know that there's a lot of hope. I mean, the majority of my work is in research, and I just have a lot of hope for the field. And where we are now wasn't, when I speak to my colleagues who started in OCD, so much progress is made, and really there's amazing progress that's exponential. If you're in the Bay Area, you're near, kind of the Stanford area, we'd love to hear from you. We put into the link OCD research at stanford.edu and my lab. So happy, if you're interested in research, great. But if you just want a connection or you want referrals locally or information, we're happy to provide that too.
Yeah. Great. Thank you so much. So if you asked a question, like I said, I'm going to put it in the chat and we will get to those questions. Thank you so much, Dr. Rodriguez, for coming out. You were great. This was like a wealth of
My
knowledge. I hope
pleasure.
people really take
Yeah.
advantage of this. Always remember, if you felt this was helpful or somebody else or for yourself and you want to rewatch it, make sure to go to youtube.com/IOCDF under live. You can watch this back. Go to iocdf.org/live streams for more information of our upcoming live streams. And then, of course, go to iocdf.org for all of your OCD support. We want to thank Dr. Rodriguez, and we want to thank you for coming out and hanging out with us for this live stream. Thank you so much, and have a beautiful rest of your day. Take care.
Thank you, Chris.
Yes, thank you so much for being on. It was great seeing you.
Yeah.
I love the green.
Yeah. Gamer headphones.
Yes, I could tell. I don't game, but I could tell. I love it.
All right. I am going to leave the studio, if that's okay, Chris.
Yes, take care.
Okay.
We will
Thanks
have you
again.
back. It was
Bye-bye.
such a pleasure.